Excellent. Okay. All right. Who did you say whichly to introduce?
Mandip.
Mandeep. Okay, Mandeep, if you could show yourself and unmute yourself. He's walking.
Sorry, I can't put it through. I'm a sixth-year medical student.
Six?
And six. Yeah,
And what do you
that's
want to do at the end of 6 years?
okay. So I was thinking first probably internship and then a master's in. Okay, depends. There are so many. I'm having a lot of confusion. So, but I have like three main choices. One being radiology, then second being family medicine, and third being something surgical. I haven't thought what.
Okay, you're definitely confused. So, be interesting to see where you end up, because those are
Mm,
very, very, very different areas of medicine. So,
mm.
when do you finish?
We finish next year, I think in June or July.
Okay. What is the typical, how many years is medical school usually?
So, okay, in Kenya, it used to be 5, but they extended it to become 6. So
Wow.
that's 6 years of studying and 1 year of internship, so 7 in total.
Wow, that's crazy. In the United States, we have shortened it, not made it longer. We've gone, shorter. Okay. All right. Well, why don't we get started? Thank you, Mandeep.
Thank
Mohammed,
you. Thank you.
thank you. Should we get started?
Yes, sure. Thank you very much, Dr. Lisa, for accepting our invite and for really accepting to come and share with us your knowledge and your expertise and all the insights that you're going to be sharing with us. We are very, very grateful to have you today. And dear members and colleagues, allow me to introduce you to Dr. Lisa. Dr. Lisa is a consultant urologist in the United States, and she's also the consultant telemedicine, telehealth, at medical director of telehealth at St. John's Hospital. So she is going to share a lot today on telemedicine and digital health. And so in the spirit of nurturing and igniting healthcare innovation in Kenya, and also within ourselves, the medical students and the healthcare science students and all the healthcare innovation enthusiasts, we have invited her today to come and share her journey and all the things she's been able to learn and how she can be able to inspire us to innovate and think around solutions that are going to solve the healthcare challenges in our country. So without further ado, I think I'll hand over to Dr. Lisa. You're welcome. Kindly take over.
Okay. I would love really fast, Mohammed, I don't know if this is possible. Can everyone turn their camera on really fast so I can get a picture of my screen with all of you people on this call, because this is really special, thanks to Mohammed. So let's do a quick photo. And
Sure.
actually, Mohammed, can you take the photo on your screen? Because I don't know how to do it really fast. and then you can send it to me.
Sure.
Okay, let's do that. Let's get all this.
Members, I think we truly opening my laptop. Meanwhile, you can be taking one as I go on.
Okay. Oh boy, this is so exciting, you guys. So exciting.
Some of us don't want to be seen. I want to take the
I
first.
know. You know, guys, everyone has to get over that. Everyone has to get over sitting at home in a t-shirt with their hair all messed up. If we're going to do Zoom calls, everybody mute though. Everyone go on mute. Okay, let's see. We don't have everybody. I'm going to do it like this, which is not the best, but I don't have everybody. If I push, let's see, Shift Command 4, I don't know how to, no, I don't know how to do it.
But I have a sample I've sent to Jamal. Maybe he can forward, and then we'll see. I've just taken a screenshot using my laptop.
Yeah. How do I, what'd you say?
I've sent up a sample to Jamal. Maybe he can
good.
forward it. Yeah, I just took a screenshot
Of course you did. Of course you did. All right, someone get the picture and then Mohammed will get it to me and I can post it on my Instagram. Okay, let's get started. So let me see if I can share my screen. Host disabled participant. Okay, host Mohammed, you need to let me share my screen since you're the host.
I think you're able to.
Oh, there we go. Okay, hold on. Let's see. All right, does everyone see the slides?
Yes, we can see the slide.
You can?
Yes.
Okay. Wait, I need to get rid of this. Okay. I don't know how to get rid of this thing over here. All right. Hold on. All right. Mohammed, is this good?
Yes, that's okay. You will share it on full screen.
How do I do that?
Sorry.
See, technologically,
How do I do that? See, technologically, is it?
Oh, there we go.
Yes. Yep.
Oh, there we go.
Yeah.
Okay. All right, let's try it. Okay. So if anyone can't hear me or if there's a problem, just jump in. All right. So this talk that I typically give to the medical school where I went to school in Philadelphia to the third-year medical students. So they just finished 2 years of sitting in the classroom and they're getting ready to go out into the clinics. So a lot of them don't have very much experience with innovation and digital health. So this is just an introduction to telemedicine. And I call this opening the digital front door. Okay. And so that's just that. The lecture, this is the third or fourth iteration of my slides because I started this lecture prior to the pandemic. The pandemic is the trigger that really allowed telemedicine to take off, as everybody knows. And I used to say that the toothpaste is out of the tube or the genie's out of the bottle, and there really is no turning back. And that is absolutely a for sure now. We know that telemedicine is woven into the fabric of our healthcare every day now. I want to also say, everybody, that I'm from the United States. I am not familiar with what your healthcare looks like in Kenya. So, like I said to Mohammed, if I say something that's not right or you can't understand, please let me know, because I don't understand your culture and what you guys are going through, and I would love to know that. I'm going to tell you my story so you could understand why I got into telemedicine. So my field of specialty is urology, so the urogenital tract. And my journey was, I went to medical school in Philadelphia, Pennsylvania. I did my general surgery and urology training in Michigan, which is another state sort of in the middle of the country. And then I moved to Wyoming, which at that point, I didn't even know where Wyoming was in America. But we made the decision, my husband and I have 2 children, and to leave Michigan because it was just crazy. I was on this treadmill of going to 5 hospitals and 4 offices, and I just needed a change. We needed a change. My husband is an anesthesiologist. So we moved to the rural state of Wyoming. Now, I have been to Kenya. We did the typical American safari trip to the Serengeti and the Masai Mara and, a few other areas. My husband's been there a few times. And so I know a little bit about what your country looks like. Wyoming is not similar, but it is very rural. And there's areas where there's very, very few people and very, very few doctors. From a urologic standpoint, there's 14 urologists in the whole state of Wyoming. In New York, where it's crowded, you can find 14 urologists standing on a corner. So it was really a culture shock for me to move to Wyoming. And I started as a solo independent doctor, my own practice, just me. And I had to grow my practice. So I started to travel, and I would drive to a small town that was about 75 miles. I don't know what that is in kilometers, each way. And I would do that twice a month. And on the other twice a month, I would fly, not me personally, but I would fly in a small plane to another town called Rock Springs. And I did that for about 12 years. And I realized that there had to be another better way to have access to my patients and my patients to have access to me. We had, he just retired, a medical director who in our state of Medicaid, which is a type of insurance for patients that don't have a big income, they can't afford insurance. And so he had an idea to buy 500 Zoom licenses that were HIPAA compliant, HIPAA meaning patient privacy, and offered it to any physician that wanted to try this telemedicine thing. And so I was one of the few that wanted to try it. And so it wasn't until really 2018 that the technology and the internet was good enough that we could try it. So this was my first patient, and she's sitting on the computer in a small town that was about 2.5 hours from me, over a huge mountain pass, the Continental Divide. And she's sitting in an office with her nurse practitioner behind her, Tracy. And this particular patient has multiple sclerosis. And she was seeing me because she couldn't urinate. She couldn't empty her bladder. So I had worked her up in the town where I live, Jackson, Wyoming, and I did a cystoscopy on her, and I did urodynamic testing to check the function of her bladder. And then after her workup, I had to teach her how to intermittent catheterize herself. And I wanted to go over how she was doing, go over her ultrasound. And I said to her, would you want to try telemedicine? You would be my first patient. You don't have to drive to see me. You don't have to make arrangements. It was like an all-day affair. She also didn't drive, had a very difficult time walking. She was ecstatic. And that was it. Once this worked, and you could see, now we take this for granted, but it wasn't, no one understood this at the time. That's when it took off for me. And I started practicing teleurology for patients that I could do follow-ups, I could review x-rays, labs, and they didn't have to drive through these canyons and overpasses to see me. Many times in Wyoming, we have a very, very long winter. As a matter of fact, even though it's August and it's summer here, it looks like it's already fall, and we're going to probably have snow soon. So winter is a huge problem. And so many times I couldn't get to my patients, and it would be months before, or a month before, they could see me. So we all know the why of telemedicine. For me, it was all about access, but now we also know that it's just very, very convenient. It's very, very efficient for all of us, for both patients and doctors. I have to say that the patients understood it a lot quicker and easier than the doctors. My fellow physicians, I have to say, are a very difficult bunch. They were very difficult to convince to try telemedicine, which is really frustrating. So it's great having you guys who are very forward thinking and want to use technology and innovation to create access. Like what Julie was saying, that we know that innovation is really the way that healthcare is just going to take off. When I would describe telemedicine to my fellow physicians, I would say that telemedicine is medicine. We don't need to create a whole different system, because all it is it's another tool for us to see patients. So teleurology is urology. Telerheumatology is rheumatology. It's not some magical thing. Telehealth is just a broader term that we use for like an umbrella term for where telemedicine comes under telehealth. This is a form of telehealth, what we're doing today. We're educating. And so that's the term that we use sometimes for telehealth, but I use them interchangeably. But it's important to understand that having somewhat of a definition, at least in the United States, is the way that our payers, our insurance companies, pay hospital systems and doctors and clinics, because when they define something and you go outside that definition, then they say, no, we're going to deny payment because it doesn't fit in exactly what we're doing. So a couple of the organizations like CMS is our Medicare and Medicaid. Medicare is our insurance system that is used for people who are 65 and older. It's kind of a universal health care, although they don't like to use that term here, but it's a way for people to get into the system when they're older and they might not be able to afford private insurance. And so we have this sort of universal healthcare system for older people that we all pay into as we're working and we're younger. So CMS describes telemedicine as professional services given to a patient through an interactive telecommunication system by a practitioner at a distant site. Whereas I looked up ChatGPT, telemedicine is a very broad definition. And this is not a payer, but this is a really nice way of looking at telemedicine. It's the delivery of healthcare services, including diagnosis, consultation, treatment, and monitoring using telecommunication technologies. It enables healthcare providers to interact with patients remotely, overcoming geographical barriers and increasing access to care. This is a really good definition, and I think it also applies to you guys living where you are. I think it just opens up the possibilities. Where we live in the United States, the states also have their own definitions. So we're really in a messy place right now. There's not one way of doing things. And to be honest with you, in America, there's never one way. There's always 100,000 ways. That makes us, it makes it interesting, but it also makes it very difficult. Telemedicine started in the United States, as I told you, with my patient in a rural setting. It was a way for CMS to get access to rural states. We now know, though, and this is what Wyoming looks like, a lot of nothing but nothing but nothing. There's a lot of wind that blows, a lot of dust that blows in between pockets of small towns, similar to where you guys are. But we also now know that it doesn't really matter if you live in a rural area. It's also applicable to urban settings, major urban areas that have millions of people. Also, we now know that telemedicine is really important for those areas as well. What we say here is that why would a patient need to get in their car, pollute the air, increase carbon emissions, take time off of work, hours off of work, sit in traffic on the highway, get to the doctor's office, try to find a parking space, and then sit in a waiting room full of sick, hacking, coughing people with the potential of getting sick. And of course, that was big during COVID, but the reality is that if you're sitting in a waiting room waiting for a doctor, you can bet that there's going to be some sick people. I'll go into also why it's not great for everything, because telemedicine is not perfect for all care, but it is great for a lot of care. One of the areas where I think telemedicine is going to shine eventually, when we can figure out a payment model, is enhanced coordination and quality of care. So for instance, Ralph, who is training to be a pharmacist, in our medical school, we have what's called interprofessional education, or IPE, where we have the medical students, the pharmacy students, we have a school of psychology, we have some other allied healthcare professionals that are within that school. And what they do is they coordinate care for a patient. And just like we're doing now on Zoom, where we have all these people on camera, we can have an enhanced coordination of care with patients. Now, I don't know how you guys do it, but in America, it's very, very fragmented. And if I wanted to say to a patient who had kidney stones, well, you need to see a nutritionist, or you need to see a nephrologist, or we need to talk to your pharmacist, it would be sending that patient to this person and this person and this person. And it's just a mess, because there's no coordination of care. Where if we can get practitioners on the same visit with the patient, we can have that ability to collaborate at once and give patients a plan. It's just a better way of treating them. Another area here where we waste a lot of money is transporting patients back and forth to either emergencies, emergency rooms, hospitals, urgent cares, when they really don't need that. They can stay at home, and we can use technology to treat them at home and not necessarily have to package them up and use an expensive ambulance or potentially a helicopter or a fixed wing plane to get them to another place, where if we can have that specialist Zoom in or video conference in with the other doctors and nurses, we can keep patients in their community. Same thing with cutting down on readmission rates. For instance, if a patient has congestive heart failure and they're discharged from the hospital, we could potentially send them home with devices and a tablet with a platform downloaded, where we can have nurses put their eyes on patients and treat them successfully at home, tweaking their medication, whatever, so that they don't have to come back to the emergency room. So telemedicine has been a lifeline during the pandemic. And when we were telling patients that you can't come in to the clinic, we have to do this telemedicine thing. Mohammed, are you there?
Yes.
Okay. So Mohammed, any questions?
So far, not yet on my side.
Okay.
Maybe the members the members are free to please put your questions in the chat box, and then towards the end, maybe after most of the session has been covered, we can open the floor for questions and interactions.
Okay. All right. That sounds good. I think it's going to be hard to get everybody. We'll do it at the end. All right. So the digital front door is a term that I have been using for a couple of years. And I think it's a really great analogy, because what is the digital front door? I like to think of it as a, kind of a real door, but it's a virtual door, where you can walk through that door and you have choices. You could go right down this hallway. You could go straight. You could make a turn. And telemedicine is similar to that, in the sense that it's really creating an experience that encourages engagement of the patient base utilizing technology. So it's a virtual care strategy. It's not just one thing. It's not just a video. It's using apps. It's using remote devices, hospital at home. It's utilizing our patient portal. It's utilizing email to ask questions. It's utilizing texts to, so you guys can understand what I'm saying. It's just a way for us to have better access to our patients for all kinds of things. I always used to say, when I first started, the telemedicine would be better if we could have patients stay at home or stay where they are, as opposed to the paradigm when I started. The rules were, as you saw, that patient, my first patient, was required to go to a rural clinic and have their telemedicine visit in that clinic. And the reason why they did that was because, again, it's all about money. And I'm always going to go back to that. It's kind of one of my pet peeves, is that in order for the insurance companies to get paid, what they would do is say to the patient, go to this medical clinic. That clinic would then get a small fee for the use of their room, and the consultant, me, would drop a code, and I would get paid as the distance site clinician. Well, when the pandemic hit and no one could come in, they had to change their rules. Thank God, because it never made sense to me to require patients to get in the car and go to a clinic. Well, now there is no turning back, because people have cell phones, people have smartphones, most places, not every place, but most places, and they can have telemedicine where they are. Okay, so the next part is innovation and technologies, and I'm going to pick on Wachuli. So can you come on camera, Wachuli, and we're going to talk a little bit about the different devices that we can use for innovation. So, Wachuli, can you see this slide?
Yes, I can.
Okay. So describe to me what you think this is showing.
For starters, everything is living on the cloud. For some reason, these devices are interconnected. So we have a doctor on one side, we have a desktop computer also generating data that is being stored in the cloud. We also have, I'm supposing this is a patient with a smartwatch. It's also generating or recording patient data, and then the data is maybe transferred to the phone and then again uploaded into the cloud. So from the doctor perspective, it seems he or she has access to these data, and the patient also has access. Yeah.
Perfect. It was far better than our medical students. Okay, have you seen any of this work in practice in real life?
It is happening in a few, let me say, well-equipped hospitals, but it has not still taken root, let me say, in our setting.
Right.
For now.
Okay. And really it's slow to be taken up as well in the United States, but this is the paradigm that we're working with right now, and it is going to take off. So just keep this in mind, and I'm going to just give you some more examples of some of these devices. Okay, so Wachuli, what happened with some of, like you just said, the forward-thinking hospital systems during COVID is that people were really inundating the hospitals, the emergency rooms, and many times they didn't need to be admitted. Yes, they were sick and maybe they needed some oxygen, maybe they needed a little bit of help, but they didn't need to be admitted. And so the hospitals were sending patients home with like a goodie box, a tablet, a pulse ox, a thermometer, maybe a blood pressure cuff. And this way they could monitor biometric data by instructing the patients on how to upload these devices, either with Bluetooth enabled or internet. And they would say to them, okay, here's the plan. Twice a day or 3 times a day, you're going to put these devices on, and this data is going to be uploaded into the cloud, which is going to come to us on a dashboard on our computer. And we're then going to get on camera with you, and we're going to put eyes on you, and we're going to look at you and make sure that you're okay and you're okay to stay at home. Or we can say, you know what? You look terrible, your temperature's up, your oxygenation is down, you know, you're in trouble, you need to come back in. This was very, very successful. I also really heard about this in Israel. Israel is very forward thinking, and they were doing this really very, very well. And there's a device that I'm going to show you that that was started in Israel. There's a couple of them. Here's one. This is called BioBeat, and you guys can look any of this stuff up on the internet. This is a company that I met at a conference, the American Telemedicine Association, where I got COVID a couple years ago. And more and more and more are they able to look at different parameters of patients. And I think they can measure like 7 different things from, you know, like I said, from their temperature to their oxygenation, to their CO2 level, to, you know, their blood sugars, and on by utilizing smartwatches and these sensors that go on your chest. And then the data is uploaded into the computer. And then you've got healthcare professionals, many times nurses or nurse practitioners, that are looking at these numbers, and then potentially, if needed, then escalated to the physician if it needs to. But it's a way to monitor patients at home. So, Julie, this is a device. Have you heard of this called TytoCare? Have you ever seen this?
Not in person. Maybe it goes by another name in our setting, but I'm seeing it's just checking how which rate is it taking per minute? Is it heart rate or respiratory rate?
Okay, so what it does is multiple things. So this stands for RPM, stands for remote patient monitoring. So it's a way to monitor patients at home. Okay, so what this is it fits in the palm of your hand. It is a high definition camera. It also has sensors that can measure your heart rate. So it can take pictures, really, really sharp pictures of whatever it is that you're taking a picture of. So they show a lesion, it can, you know, a rash, your skin, a wound, anything really. But what the nice thing about this also is it has a tongue depressor. So you can look down the throat on a sick child or a sick person in your family and look at the back of the throat. And the magnification is amazing. It goes on to the physician's iPad. The other thing is this teleotoscope, which is right here, that if you can instruct a patient on how to use this, and you guys know that looking in the ear is not the easiest thing to do, to look at the tympanic membrane, but as they stick it in the ear and they get to the tympanic membrane, the device has like a check mark or a green check mark that says success, that you're there, and it shows the tympanic membrane. And you guys can go on TytoCare's website and look. They have videos that show this. Now, the thing about innovation is, so the devices are almost the easy part now. These companies have just done unbelievably well with their creative engineers, but the practicality is the problem. So these devices, when it first came out in the States, they gave it to a company called Best Buy that has like televisions and computers and all kinds of stuff. And it's sold for $299 or something like that. And unfortunately, so it's expensive, number one. Number two is, in order to scale this up, to get it into thousands and millions of people, they really needed to partner with our insurance payers. And that's when everything just falls apart, when you have these third-party payers that get involved to try to make money. Thank you, Mohammed. And so not everybody has access to this device unless you are with an insurance company that provides them to their patients as a benefit and their physicians. But it will get there. This will be democratized to everybody eventually, where if you have a mom or dad that has sick kids at home, they will be able to do these exams at home, send the images asynchronously, which is how things are headed, for the doctor to look at these images, make a diagnosis, potentially e-prescribe a prescription, and everything will be done digitally. So, Wachuli, what do you think about that?
In terms of the concept, I believe this will be the second time I see something like this. Somebody thinking along that line, a device that's able to capture more than one metric that is continuously uploaded, stored somewhere so that the physician can see. Because there were some students from another university here, they're also thinking of the same, but the device they had was actually bulky, but it's supposed to now take these measurements from a neonate or an infant, and then capture maybe the skin condition, capture a few other details. So I think it's something that we, as we appreciate the technology advancing and also the politics around all of it, I think it's something that can work given enough time.
Right. Miles asked about Theranos. Are you talking about Theranos, like the company that went under?
No, not really, not really.
I don't know what that is. Oh, right. He is talking about that. That's so funny, Elizabeth Holmes. Well, she's in jail. And so no, this is real life. This works. This is not a, pie in the sky scheme, Miles. This actually works and works very, very well. Okay, here we go. So, Wachuli, this is a telestethoscope. Have you used that at all?
No, can barely use the normal one, but
right.
I
Well,
understand
and this has multiple uses for that. So this is another, Mohammed, if you can look up Echo, EKO. This is another company that has also taken off. And I was able to look at the company when it was first starting, and it was not that great with the ability to hear, unless everything was just perfect, the technology, but they've gotten better and better and better. And so it has a couple uses. One is for teaching, like you were just saying, Wachuli, it can magnify, the heart sounds, the lung sounds, but it also can be used and was really invented for telemedicine. And I heard about it because there was a pediatric cardiology group in Denver, which is in Colorado, that was seeing kids that were in Cheyenne, Wyoming, and the echo was used in Wyoming on the kids, and the cardiologist in Colorado could listen with their earphones and hear in really, really sharp definition what was going on with the heart sounds and the murmurs of that child, so that the child did not have to travel across state lines to go see their pediatric cardiologist. So telestethoscopes is another really great teaching device that you guys may want to look into. The wide angle webcams are simple and fairly cheap to, thanks, Mohammed, for doing that. But it also is another great way that we can see our patients better. So similar to TytoCare, where they have this high definition camera, you can hook up these Logitech cameras and whatever companies you guys have there to patients' devices at home, and you get this broad, wide angle view of what's going on in their home. So some of the cameras that we have on these laptops are not that great, but you could, if for instance, and I say this in America, is that if a patient was going through rehab after an orthopedic surgery, like a total joint surgery, or the patient had a stroke and they wanted to go through rehab, and you could see the obstacles in their home. You can look and see what they have available where they live, rather than having the patient come to our offices, which is not real life, and give them exercises to do, and the patients go home and they're like, yeah, whatever, and they just throw the thing in the trash and they never do it. But this sort of makes accountability for patients, because you can meet them at their house utilizing a camera to see what's going on in their home. So this is also ophthalmology, teleophthalmology. And also, Mohammed, maybe also put in the chat my beyondtelehealth.org. And I have been recording over the past 3 years on a platform that puts my interviews on YouTube. So if you go on beyondtelehealth.org and click on the YouTube link and go to the videos, you'll see multiple interviews with different physicians. And one of them is a ophthalmologist who had just finished his residency at Harvard, I think, and was really on a mission to get devices into rural clinics and ERs where ophthalmologists, thanks, Mohammed, that can look at really unbelievable images of the front of the eye and the back of the eye, rather than having the patient have to come to the ophthalmologist. Because in America, we don't have a lot of specialists in all of these areas, in rural, remote areas. And ophthalmology, similar to radiology, is one of the fields that has utilized fancy images and technology, but they haven't, again, democratized it because it's expensive. But ultimately, with these handheld devices, we're going to be able to allow the ophthalmologist to make diagnoses and help practitioners from rural clinics utilizing these devices. Okay, so literally this is I used to say this is the future, but it's not. This is happening now and has been happening for several years. I would call this guy a virtualist. He calls himself a telecritical care specialist or telestroke. This is tele-NICU, tele-neonatal intensive care. So let me just talk a little bit about this. This physician is monitoring several different intensive care units around their metropolitan area. So where we are, Utah, in Salt Lake City, they have what they call a virtual hospital, where their intensivists take turns doing this virtual shift, where they sit in front of a bank of computers and working with nurses and doctors that don't necessarily have medical or surgical intensivists, that have the ability to send their images, their MRIs, their CAT scans of their brain, of whatever, wherever, whatever. And they can help guide the physicians there's a patient on here, but typically it's just peer-to-peer, it's physician to physician. But this can be done in any specialty, right? We can do it in orthopedics. We can look at all these different fancy images. And if we're honest with ourselves, as you guys know, that you're learning, you're in medical school. And I have a feeling that most of your training is very traditional, where, and it's same here in the States, where you're taught about touching patients and physical examination and hands-on. And what I'm suggesting, and it's not for everything, but this virtual world that we're going to be in is more about images and the technology that we have to be able to look inside of people. We can't replace touching. We can't replace giving people hugs. There's nothing like that. But again, I would say, and I was trained, I love touching my patients. I loved hugging my patients. But the reality is that 80% of the time, we don't need to do that. 20% of the time, we do. We need to put our hands on patients. But many times it's, okay, you have blood in your urine. I need to get a CAT scan of your kidneys, and then we can figure out what's going on. I can look in your bladder to make sure that you don't have a small bladder tumor, but many times the images can show us what we need to know. There are no secrets anymore with PET scans and MRIs and CAT scans and nuclear studies. So anyway, this is the virtualist. The neonatal tele-NICU is another program that's been around for 5 years or so. I met a very forward-thinking neonatologist who his goal is to keep sick babies in their communities if possible. If we can keep babies with their mothers, with their families, in their communities, and help uplift the pediatricians, the hospitalists, to help take care, the nurses, to help take care of the babies where they are, and we don't have to ship them. So here's the neonatologist on camera talking to the doctor. Here's the baby, the camera's here, looking at the baby in the warmer. Julie, what do you think of this?
I think if given 5 years, I wouldn't have come up, even appreciated that something like this is possible in the first place. So seeing it being, you said it's no longer a dream, it's a reality. And you've mentioned some of the things that would function as barriers. For example, the traditional paradigm of you have to taking a history and doing a physical examination is 80% of you getting the diagnosis from a patient. We have such sentiments from the people who instruct us, and they're built into us. So it's just a matter of trying to integrate because these things, they keep changing. People who came up with maybe a specific physical exam that will be able to nail a particular diagnosis. There was a way people were doing this before that came. So now we have a new way of trying to get this diagnosis faster, care for this patient faster. So it's interesting.
Yeah. Many of those people are dead, right? that they're named after. Yeah. And so you're right. This is progress. We cannot turn back the clock. We're moving forward fast and furious. All right, here's another one. So this is a company called Butterfly, and Mohammed, you could find them. And there's a few of them. Philips, I don't know if Siemens. There's a lot of companies that have these handheld ultrasounds that fit in your pocket, in your white lab coat. And these have been around for a while as well, but the concept of utilizing telemedicine is partly what's new. So ultrasound in my world as a urologist is we've used ultrasound for many years, But what's changing is the ability to diagnose utilizing ultrasound technology for many, many, many other things. Cardiology with echoes and on and on and on and on. But what's happened over the past however many years is that doctors are doing fellowships in ultrasound, because ultrasound is not an easy anatomical way of looking at things, because it's a lot of gray and white and black. It's not necessarily in 3D, where, you know, we can utilize CAT scans and MRIs and PET scans and put them in 3D, which is how our brains like to think. But emergency room physicians are becoming very, very adept. Urologists are becoming very, very adept at utilizing handheld ultrasound to make diagnoses on their own. But let's say you're out in the field, in the wilderness, you're in the middle of Mount Everest or somewhere where you want to make a diagnosis, but you're not necessarily the specialist, the radiologist, the ultrasonographer that can look at these images. And you can hook this up to a smart device and have these images sent to a radiologist to look at through, you know, telehealth, telemedicine, to say, no, you know, this is what I think, let's position the ultrasound this way. So another, you know, just idea is, and this is a little out there right now, but, you know, just me thinking, is why couldn't we give these devices to moms to, you know, look at their baby in utero and use the Doppler and check out the heart sounds and look at the baby. People and patients can be taught to do lots of things. And so again, we're democratizing technology and getting them in the hands of our patients. Very controversial at this point, but I'm just putting that thought out there. Okay, here we go. So Wichuli, open up your mind, and which your mind is already opened, but this is what we call a Bala Wow. So Bala is a nursing home facility that's near Philadelphia and my medical school. There is a geriatrician who had this idea several years ago. She was turned down for a grant, but then COVID hit and the grant went through. And her study is to use the WOW. The WOW stands for Workstation on Wheels. So she calls it the Bala Wow. And this is a telemedicine cart. Have you seen this, Wichuli, at all?
At the moment, no, not.
Okay. So what this is similar to what I was just talking about. This is the sort of all-in-one. And we also call this in emergency rooms to utilize for telestroke. They wheel this cart into the patient's room. And this cart is loaded with a tele-stethoscope, a tele-otoscope, a high-def camera, and also this camera that swivels. And the physician on the other end has control over that camera. So they can swivel the camera, zoom in on the patient's pupils, zoom out, look at the room, as opposed to this handheld camera where the nurse or the medical student can then take that camera and look at a rash or look at a wound. Now, I happened to go to Philly and work with these two to try to get this off the ground because they were struggling a little bit. Now, the secret sauce is this guy in black at the time. He was a biomedical engineering master's student who was responsible for making sure that the technology was working. So the paradigm is, the study is, it's about remote supervision of medical students. So what we did was we wheeled this cart into that room, and there's a patient that was being readmitted from the hospital back to the nursing home. This particular patient was perfect in the sense that he was excited. I asked him if he would allow us to use this cart to examine him. And this guy had a tracheostomy. He had a feeding tube, so he had a peg. He was contracted. He had decubitus ulcers, wounds from laying in bed. So he really couldn't talk. His oral hygiene was terrible, but he was happy. He was happy to let us do this. And what happened is the geriatrician was on camera, and my brother, who was a family medicine doctor, it was his patient. So he was on camera. And what we did was we wheeled this in and we used all these devices. We looked at his trach site and his peg site and his wounds. And we were able to do a full history and physical with Julie and readmit him and have a full note done. And so the study was, can medical students do this? Wheel the cart in and have their supervising physician watch them as they utilize these devices. Now, the reason why I say that this guy is the secret sauce is because let's say that it's your average nurse and medical student who doesn't know how to get this technology working, that they're stressed out about, oh my God, is it plugged in? How do I get this telestethoscope to work? Well, wouldn't it be great if we had somebody like Wachuli who understands technology to make sure that we don't have to worry about the technology, that he says, okay, it's good to go. So again, this is happening. This is happening now. The study is, I think, has ended, and they've done 200, if I heard her correctly. I'm waiting for her to push the results of the grant to say, is remote supervision the same as, better than, or worse than in real life? We're waiting for this information. The government wants to know, the insurance companies want to know, the medical schools want to know, does this work? Okay, Julie, what do you think of that?
It can work. It can work.
It's good.
Yeah, it can work. It can work because now we are thinking of currently the generation we have is that of professionals who are conversant with technology. So if we are talking medical students who are going to be absorbed into a practice in a few years, then they better start getting acquainted with some of these devices. So by the time they are they start practicing, because we've mentioned so many other advances going on almost everywhere. So they'll have an easier time trying to use these tools by the time they get into practice.
Awesome. Mohammed, I have no idea what you just asked me. Who's Wendy?
Oh, I said we could also have other members and stuff. For example, maybe Wendy can also answer the
Okay,
next
so
question.
Do you want to switch to Wendy?
Sure.
Okay. All right, Wachuli, let's switch to Wendy.
Perfect.
Thank you. Wendy, can you just show me your face? Is Wendy there? I don't know if Wendy's a boy or a girl. In my world, Wendy is a girl.
I think we might have ambushed her. I'm sorry. Maybe we can continue as she prepares for the next question.
Okay, does anyone else want to come on? Does anyone want to volunteer? Mohammed, you want to pick someone else?
Yeah. We have Dr. Mohammed Ahmed. Dr. Mohammed.
Dr. Mohammed? Let's see. Can you get on?
Yeah. Thanks a
There-
lot. I appreciate.
Okay. All right.
Hi. So I'm really the type that is quite interested in these medical devices that can be done remotely. I'm a medical officer, and as a GP, I've seen a lot of patients for almost some 8 years now, and whatever you have shared right now makes a lot of sense to me. And I think with the current generation, we're on the right track. And if this is exactly what's coming or what's projected to be the future, some places like Japan, they're already living the future. I think it's just about time to not to reinvent the wheel. Just the matter of exposure. And I really appreciate being part of this. I think I'm learning a lot. Thank you. Thank you, Doctor.
Yes, you're welcome. You're welcome. Okay, well, stay on for a sec because we'll banter back and forth. So this is a picture of the back on the back of an ambulance at Emory, which is a medical school in Georgia. And these guys are part of this grant that I'm also involved with. And Emory is very forward thinking, but it's taken a long time and a lot of money to get these things off the ground. So basically, what this is showing is you've got this camera up here, which allows the ER physicians at the university to see what's happening real time in the ambulance with the EMTs who are transporting a critical patient. And here's the computer screen that also is transmitting or uploading the data from the EKG from whatever devices they are hooking the patient up to. And here you can see this happy emergency room physician who is watching this happen. And the beauty of this is that, again, it's about coordination of care, continuity of care, collegiality with tertiary care, or what we call quaternary care medicine, for potentially very remote areas, but even urban areas. So as this patient is being taken care of real time, the emergency room physician gets a sort of a finger on the pulse. Before that patient arrives in their emergency room, they can be better prepared. Again, they've got eyes on the patient. So it's not just a phone call. It's not just, okay, this is what's happening. He can actually, or she can actually see what's happening real time, so that when the patient gets to the emergency room, they know, okay, get the CAT scan ready. Call the surgeon, get the surgeon ready. This is truly an emergency. Or they could say, you know what, everybody take a deep breath, right? We don't need to pull out the team and get everybody involved. This is not as complicated as we think. So you get the idea that the video component, the audio component, the devices, all of this stuff as it's transmitted real time is important. The other part, though, is the ability to utilize the internet. And that's a struggle that I'm sure you guys have, as we do for sure in Wyoming, when these patients are transported through canyons and through areas where there's no connectivity. So our government has finally realized, now how long it's going to take, we don't know, but to try to get fiber and fast fiber into, as many areas as we possibly can. We know that satellite works, all different ways of utilizing broadband technology to connect people. I mean, here we are. I can't even believe, this is all because of Muhammad, who reached out. I'm talking to you guys. I'm sitting in Wyoming and you guys are in Kenya, for crying out loud. Like, this is crazy, but it's not crazy. Okay, we talked about this. We'll skip this slide. This is training you guys. All right, now let's see. I've been talking for a long time. Mohammed, do you want me to keep going? Or Dr. Mohammed, do you want me to keep moving? Let's see. Okay.
Sure.
Okay.
Whatever you feel comfortable with, any time you feel you want to stop, we'll work with that.
Okay. Let me go for like another 10 or 15 minutes, okay?
Sure. Thank you.
Okay. So this type of telemedicine is a little different than what I was talking about. This is direct-to-consumer telemedicine. The latest thing in our news is Amazon Clinic. It has gotten into the game, and we know that this is happening with these big companies, CVS and Walmart, Walgreens, that want to utilize this type of telemedicine for very quick and easy type visits where a patient can pay cash. So Teladoc was one of the original companies that started this model, and this was over 10 years ago. MD Live was another one that was bought out. Amazon Clinic will probably be a game changer if it is successful. They are actively utilizing AI in their in their ability to document health scribe, so that we have augmented intelligence and artificial intelligence as physicians in the Amazon world are having an interaction with a patient, that AI is documenting, utilizing ambient dictation, and getting their documentation right into their health records. So this is just one small example, which I think is great because I can't type and think at the same time because I'm old, is that if we can have AI that's documenting as I'm speaking accurately, pulling out what's important, not the side comments about how's the weather, but making a medical note that's concise and appropriate and putting it in the chart so that we don't have to do that and take time out of our day to make sure that the medical record is done properly. If AI can take that off our backs, holy cow, would that be great? So AI does have the potential to revolutionize and is revolutionizing healthcare and has been. And I'm just throwing these things out, planting the seeds. We have mixed reality. We have augmented reality. I personally like this in education. I've always loved educating my patients on what surgery is. If if I had to take out a kidney or do a prostatectomy or a transurethral resection of the prostate, these are difficult concepts to even physicians have a hard time understanding what a transurethral resection of a prostate is. If you can utilize augmented reality and get that patient or physician, medical student, immersed in the anatomy, 3D, to look at a prostate and what it looks like, it's just the next step up from YouTube, right? Where things are in 3D. So this again is what they were doing in Israel in regards to utilizing augmented reality in the office with planning and education, in the operating room, where we have guidance in real time utilizing mixed reality technology. So this is also happening now. Okay, so the metaverse. I mean, holy cow. People say to me, you know, Dr. Finkelstein, what are you talking about? Well, I don't even know. I mean, it's beyond my comprehension, but it's going to be in your world. The metaverse will connect people to new experiences, from immersive education and training and new possibilities in healthcare. And what I want to say to you guys, and I know I'm preaching to the choir here, but rather than, you know, Mark Zuckerberg's metaverse, is Mohammed and Wachuli and Dr. Mohammed and Wendy, all you guys are going to hopefully be the champions to tell Mark Zuckerberg what healthcare is going to look like in the metaverse, and not let them tell you how to utilize it in your healthcare journey. We talked about this. I'm not going to go through this stuff because this is more pertains to the United States. Licensing is an issue where we are. We're working on an interstate licensing compact. So the other part of, and I'll just run through this also fast, is that telemedicine. I found this on the web. Oh boy, that was my watch spying on me. So telemedicine, as I said, is not for everybody and everything. So if we have a patient that we have on camera that's not appropriate, we have to say no. We have to be able to use what I call our webside manner, similar to our bedside manner, and be very appropriate and very deliberate in how we talk to our patients on camera. So perception is reality. If you present yourself, you know, in a corner, wearing a rumpled t-shirt, the audio isn't great, the video isn't great, that's not appropriate. If we were in real life, we would not do that, hopefully. Now, there are some physicians that, you know, take advantage of things and don't do things appropriately. Most of us, though, do. And I would recommend to your teachers and your supervisors that you teach your students how to present themselves on camera virtually, very similarly that they do in real life, that they sit up tall, they wear their coat, they have their ID, that you have your ID, guys, and you say, I'm Dr. Mohammed, I'm a urologist, and present yourself in a very professional way so that they know that you're listening to them on camera, that they're not being disregarded. Because I can tell you that if you don't, you're not going to earn the trust of the patient. You're not going to get good reviews if that's important to you. You need to show them similar empathy on camera that you would if you were in real life. The other important thing is to be able to say no to your patient, that if you feel that it's unsafe for the patient, that they're not in a good environment. I mean, we've had stories that are just crazy where people are driving and trying to have a virtual visit with their doctor. That's a no. You say, no, this is dangerous. We cannot do this while you're driving. You know, why would I have to say that? But people do all kinds of weird stuff. Either you pull over to the side of the road and stop the car, or we reschedule this telemedicine visit. It's not appropriate for the patient to be smoking in front of their physician. They would never do that in the clinic. The other aspect, though, is the comfort level of the doctor. Now, I'm a urologist. I examine the most sensitive genitalia parts of the body. And I've been doing this for 30 years. I feel very comfortable examining genitalia. if I have a patient that says, you know, Dr. Finkelstein, can you, I want to show you this thing on my penis. I've had, you know, funny experiences where older men that have big bellies and they say, I can't find my penis. And I feel very comfortable saying to a patient, stand up, drop your pants, and show me. You can have family members, a wife there with the patient. You could have a chaperone in the room. You can look at wounds. It's your comfort level. And as you're learning, because you guys are just learning, but eventually, you know, Dr. Muhammad's been out for 8 years. He might feel more comfortable examining a patient on camera. So there's all different iterations of comfort levels. Okay, I'll leave you guys with this. So this is the hype cycle, which maybe some of you know about. And this is what is happening right now. So we have a trigger to trigger innovation, and that is COVID-19, the pandemic. Without the pandemic, we would have 10 more years of this discussion. That's what I thought when I first started doing this. And I mean, initially I started thinking about it in 2010. 2018 was my first patient. I thought, okay, 10 more years of convincing my peers to do, you know, to utilize telemedicine. Well, literally overnight, people were calling me, Lisa, how do we do this telemedicine thing? I can't see my patients. And without that, we wouldn't have been able to have this sudden surge of inflated expectations and technology. But what's happened as the pandemic has started to ease, that patients then say, you know what, I don't want to Zoom anymore. I want to come in, give my doctor a hug, have them touch me. And so we're going down into this sort of trough of disillusionment. But really, we're starting to come out of it because people and students like you who found me and say, no, you know, we're headed into this slope of enlightenment here where there's going to be a plateau of productivity, where you're going to see forward-thinking people utilizing technology to keep going, right? And maintain this momentum. We've had a lapse in the momentum, but we'll get back there. And so that's sort of where we are in this phase right now. Here's some resources that we use here in the United States. This is really one of my favorite ones, the CCHPCA, Center for Connected Health Policy, that is a wonderful organization that talks about policy, public health, keeps us up to date, keeps me up to date. I will leave you with this. Be a champion. Be a champion in innovation. And what I'd like to say with my 5 minutes with Fink, which is on Instagram, where I cover a telehealth concept every Friday morning. You can follow me on Instagram. And I say, keep calm and tele on. So I am going to stop sharing and open this up to you guys. Any questions?
Thank you so much, Dr. Lisa. This session has really went way far beyond my personal expectations. I knew it was going to be very exciting and enlightening, but it has really gone much beyond what I could ever imagine. And that's a really important thing to me personally, because I'm very interested in telehealth, and I know there are other colleagues as well who are here. So we want to really thank you so much for taking the time to come and share all this with us. And maybe now we can have questions from the members. Feel free, guys, to unmute. Feel free to type out the questions. I can see one, what are the risks with telehealth apart from legal issues?
Yeah. So it's risks, challenges, and barriers, Miles. And just like anything new, there are many. And, risks of technology are always where we talk about privacy and, people getting information. And that's above my level. I'm just a doctor, and my brain doesn't necessarily go to the dark side. But we have to think about that, and we need to make sure that we understand that there are risks to innovation, and people out there in security and data and analytics are looking at that. AI, as you guys all know, is in the news. You're welcome, everybody. Is in the news, and we know that it can be used for good and for bad. And those are risks whenever we have humans, unfortunately. The barriers for us are adoption, right? And so I would say to you guys, go to the people that want to know about this. The physicians that don't want to be a part of this, say, that's okay. You guys keep doing what you're doing, and that's okay. But the people and the patients that are interested in this type of world where progress is happening, that's really where you want to get them. You want to get them on board. So for me, I would leave the physicians behind and go to my patients and say, please ask for telehealth. Ask your doctors if they can provide this visit to renew your medicines or review labs or images. Do simple things. But if the patients start asking for it, then the physicians will have to start slowly coming on board. Again, the pandemic helped that happen, but we're starting to move back a little bit. So be forward thinking with your patients, with your mentors, with your teachers, with your deans. Don't be afraid to talk about these things. So those are the challenges. Barriers for us also are licensing, because not every physician is licensed in every state, and that's a whole nother lecture. I think that blockchain has a application for licensing for physicians, really, in the United States and across the world. And but people are not willing to go there at this point, because they want the power. They want the power to be able to license. So it's complicated, right? We've got politics and politicians. Those are some risks and barriers. Anybody else have a question? And you guys are very, very welcome.
I have a concern rather, because I have been going through a bit of studies looking at bioinformatics and health informatics, and I don't know, I'm seeing most of the professions training informaticists, maybe nurses, and one thing that stood out is bias, because some of these devices are being created, maybe being trained with with the data that is used to train, for example, a certain sensor that's taking some vital sign somewhere. There's a lot of bias still, even though we are also talking about a barrier to them being adopted, being some of the physicians also not being just open to having these devices coming to their practice. But a concern, not really maybe a question, but there's there's bias in training some of these or maybe calibrating some of these devices. I don't know what steps are being taken from the work that you've seen being done to try and eliminate this bias.
Yeah, this is happening all over the world as well. We realize, I mean, I come from the perspective of what I call the wealthy, right? And white, the well, the wealthy. And my perspective is very different than someone else's perspective. It's bias is everywhere in real life when we deal with patients, from everywhere. So, when I'm seeing patients in rural Wyoming, let's say where there's drilling for oil and gas and it's a different population, you guys, I mean, truly, it's human nature to be biased, right? And how do we get beyond that? I think that everyone, that's where you guys come in, right? Your friends, your family, everyone has to be a part of this. And it's the people, I call us the do-gooders, the people that want to do good in the world, that want to include everybody. So the universities, everyone is talking about bias, the inequities in our societies and in our healthcare, the rich and the poor. How do we get beyond that? I mean, these are massive questions, but we have to keep striving to include everybody in when we are inventing these devices and AI and how the information is digested. So you guys are going to be a part of it, which truly, if you start working for a large company that does coding and, whatever it is, data analytics, your voice needs to be heard. You have to stand up and shout from the rafters, and don't be afraid to say, no, you need to think about it like this, and you need to think about it like this. Not a great answer, but I'm on your page.
I get it. Because as you've mentioned, maybe some of the innovations that from your end you see coming up day in, day out, it's very easy to target the population because most of the people are able to accept them in terms of capacity. They are financially able, even if they're not. There's insurance cover that's doing that. Because on our end, we might want to have these telemedicine platforms flourishing, but you find insurance is not even something, I don't know, the perception is already wrong. Maybe somebody sees their money going for I don't know how many years, they're not getting sick. So the coverage again is low. You talk about basic internet connectivity. It's good, but now, because if someone from your end is trying to implement such a platform, their problem might be now, how do I make this video clear? Make sure that this patient understands this platform. But when somebody from my side, if I'm trying to implement such a platform, I'm also thinking of now, how are they even going to get constant or good quality internet connection to try and do that? So yeah, it raises some questions, but we just have to keep
I have to keep looking away. And as I say with Truly, it takes a village to make this happen. This is not easy stuff. It takes family support. It takes grandchildren to help their grandparents with technology. If they can't have reliable internet, is there a rural clinic that has reliable internet where people can come to that clinic to get reliable internet, a private room where they can talk privately? We're looking at public spaces, libraries that may have kiosks, public health clinics that have public health nurses. So it takes a huge amount of people to think out of the box. But I would say start small. And that's really how it happened for me. Because our CEO, when I came to him and said, I want to do telemedicine, and he said to me, Lisa, if you can make it work in urology, go for it. And I focused on what I did. And I found that I could figure it out. And then little by little, you start to talk to people that want to make it work. And so if you have, let's say, a family doctor or a cardiologist that wants to look at their patients that have congestive heart failure and just utilize a couple of devices at home. So I say to the physicians, make it your own. Don't listen to me, Dr. Finkelstein, tell you what to do. You have ideas. You make it your own. Pulmonologists, sleep medicine, endocrine, their brains think different than me as a urologist. And I say, great. If that's what you think is the best use case scenario, go for it. So don't get so overwhelmed. Try to focus in on a small little project.
Thank you, thank you. I don't know from the rest of us if we have any other questions or comments. Feel free to unmute and engage.
All right. Well, it looks like.
Hello.
Oh, here's somebody. Wendy. Hi, Wendy.
Yeah, mine's not a question, maybe more of a comment or like feedback. Thank you so much for this session. It's been great learning from your experience with telemedicine in the US, some of the progress and challenges. Yeah, so while it's an aspect that still needs to be improved in our country, I think it will be really great to have it and sort of minimize the strain on our health systems and like improve access to care. So it's something I'll personally love to venture into. So this has been a really nice session, and how you brought out the incorporation with like other aspects like AI and all these remote devices. Yeah, so thank you so much. And I look forward to our countries developing like frameworks and enabling environments for you to pick up. I personally will be like one of the doctors advocating for it with my patients. So thank you.
You're welcome. And that's, if I can convince a couple of you guys to, like I said, be a champion, then I did my job. You're welcome, Mark, and everybody. How about if Mohammed stays on for a minute, but you guys can all sign off and we'll just close out. Is that okay?
Maybe we can all reveal our videos and say bye-bye to our consultants. We will.
I love seeing your faces. There's Mark. My husband's name is Mark with a C.
That's so exciting. I always find people who have it with a K, and I'm just like, there's a special group with a C. Like
right.
we're the cool ones.
Right. That's so funny. Oh, look at you guys.
We can wave and also unmute and say bye and thank you to Dr. Lisa.
Might be a lot of.
Thank you.
Bye. Thank you so much.
Bye.
Bye.
Bye.